So the majority of our patients we know with upfront therapies will go into remission with intensive chemotherapy up to half to 2/3, and after venetoclax, azacitidine, again about 2/3 of patients going into remission. However, we know that with venetoclax HMA therapy, everybody is going to relapse, and the median overall survival after 4 years is still 13.9 months. We know also that about half of our patients with intensive chemotherapy are also going to relapse. So maintaining remission has become the new way to maintain quality of life, transfusion independence. We are increasingly looking at minimal or measurable residual disease to predict which one of our patients who are in morphological remission are going to relapse, and we're increasingly looking for that MRD eraser, something to eradicate MRD disease. Now, over the last few years, we've looked at oral chemotherapy or azacitidine and intriguing data with the Quasar study, looking at whether that can eradicate MRD. And a lot of our immune therapies, for example, bispecific therapies for AML, are also focusing on MRD. MRD has become the new way for us to track this and to prolong the overall survival. So looking forward to targeted therapies. We now know that FLT3 inhibitors can reduce relapse-free, increase relapse-free survival in patients that are MRD positive prior to or immediately following allogeneic stem cell transplantation. We're looking at IDH1, IDH2 inhibitors, as well as menin inhibitors to try to, again, target those patients that are at risk for MRD, with the paradigm being pH-positive acute leukemia. So I think that increasingly, as we look to an older, less fit population, we're not able to get allogeneic stem cell transplantation. This is going to be the next, I think, barrier that we're going to need to face, is how to prolong survival in these patients.